communities, and thank you all for coming with us. The session today is a hybrid session, so we have people joining us online as well as in person, so thank you to everyone. I have some just housekeeping rules I'm just going to start off the session with. So to begin with, just to ask you, if you haven't already done so, if you could download the conference app. If you search for 32 Alzheimer Europe Conference, you'll find the app, and that way you can ask questions online. They'll be moderated on here so that people on the hybrid session can also see your questions and vice versa. However, there will also be a microphone in the room, but I will be looking at the social Q&A first for the hybrid session. Also, to remind you that we have poster presentations in the Constanta room, so if you haven't been to see some of the excellent posters which are there, and also some of the stands from Alzheimer Europe, from the European Working Group of People with Dementia, there's also a stand in there, so we'd encourage you to go there. And also, there's a QR code on the pop-up banner just outside Constanta where you can get the QR code to vote for the best poster, and we have the presentation, so you'll be able to vote until 4 p.m. On Wednesday, and you will need to select 5 posters in each of the categories. So that's my housekeeping rules, so I won't get in trouble from Gladys, our conference organizer. Just to remind people as well today that I will have each of the speakers has 12 minutes, so I have my 5 minutes, 1 minute, and my stop card, so I'm a bit like a football referee today, but I'm hoping for a good-tempered game and everyone to play fairly. So I'm really pleased to be able to introduce this topic today. It's something which Alzheimer Europe developed a yearbook on last year. I think in the past decade, the amount of work that has been done in relation to dementia-friendly communities has been just growing, and it's covered a real sort of broad range of topics. So I'm really excited to hear from the presenters today, and I'm looking forward to the contributions. So without further ado, I shall pass on to our first speaker, who is Marjolein Thijssen, who is going to talk about the success factors of community dementia-friendly initiatives using a realist review and evaluation. So the floor is yours.
Thank you very much. Oh, this is another one. Good morning, good afternoon, everyone. Today I will be presenting some results of my PhD project, and you can see on the first slide I'm in very good company. And my PhD is about success factors of dementia-friendly initiatives. And it's about dementia-friendly initiatives in the community. And the project is called Mentality, so that's the name that you see most of the time. I will talk a bit about the use of the realist evaluation and the Dutch context, but very shortly because of the time. I will focus on the results in 3 projects. I will focus on the outcomes of dementia-friendly initiatives as according to people with dementia and their carers. I will talk about the development and sustainment of dementia-friendly initiatives in the community and what matters. And then, based on those results, I will focus on the interdisciplinary collaboration during development and sustainment of dementia-friendly initiatives. Well, I think you're an audience to which I do not have to explain the importance of dementia-friendly communities and initiatives, so therefore I kept this very shortly. There are multiple reasons for dementia-friendly initiatives and communities, of which I also would like to emphasize the one of the human rights movement, which supports the inclusion of all people. And the focus of dementia-friendly, the focus of Mentality is to focus on dementia-friendly initiatives and to understand what kind of community dementia-friendly initiatives work, for whom, in what circumstances, why and how these are related. The use of the realist approach encourages us to go deeper, and the realist approach is often symbolized by an iceberg. The realist approach focuses on mechanisms, and what you should remember is what is hidden matters the most, and therefore the iceberg is a good metaphor, which shows the first picture. And for us, it meant that during our project, we focused on looking for evidence by extracting context, mechanism, and outcome configurations, which helps us to explain why things were happening. And we conducted that in all 3 phases, a rapid realist review, a multiple case study, and a realist evaluation. In the first part, there was a literature review. We focused on outcomes of dementia-friendly initiatives, and of many papers, we selected 22 papers which were done in the community and which used outcomes in which empirical data of people with dementia and carers were used. And we categorized them in dementia specific initiatives, which, for example, were Alzheimer cafes or adapted pavement. We also had dementia-inclusive initiatives, which were initiatives or activities that were already existing but were adapted to people with dementia, for example, a choir or a museum. And then we had initiatives which focused on awareness, and those were often organized also with people with dementia, for example, a congress or a theater. And we call them, what we saw on our data is that the first one really brought for a caring community, the second one a stimulating community, and the third one an activating community. So there was a new context. So what did that mean for the outcomes? And I've summarized it here, focusing on the outcomes, and the mechanisms that are behind it are written down in the source in my review that was published. The caring community really provided a possibility for people with dementia to have contact, waving to other people. And for carers, it was a community in which problems could be solved. However, often problems and symptoms were at the center, and therefore the role of a patient was more at the center than in the other ones. For example, in the stimulating communities, outcomes were found as being able to connect with people, having fun together, and a stress reduction, also by the caregiver. And people expressed in the quotes of the papers that they were also a part of the team, like, I'm cheering also for the other ones. And in the third one, the activating community, people with dementia reported outcomes in which they were engaging and also initiating things for the activity, but also outside. For example, initiating, searching for the support that they needed. It was more like being a citizen. But it was important insight for us. And in a second phase, we looked behind the scenes and we focused on what matters in developing and sustaining those initiatives. Well, I could say for the Dutch context that there could be many people involved because community dementia-friendly initiatives are very locally organized, often initiated by a municipality who has an ambition to become dementia-friendly. And here I have summarized some of the stakeholders that are important in developing. And some municipalities, they're all present. In some municipalities, they aren't. It's often the question if the people with dementia and their carers are also visible in the development and sustainment. Oh, the next one. What we saw, we visited 4 best practices, as we call them, in several parts of Netherlands. You can see that. And we talked and observed and did many things, also observations, with stakeholders who were involved in setting up and sustaining dementia-friendly initiatives. There were different one of them, adapting pavements, but also Odense housing, also a dementia-friendly museum and a dementia-friendly choir. And it's good to know that we used a network sampling of stakeholders. So when we talk to people, we ask them, could you advise to us someone? We should also talk about it if we want to understand what happened. And in total, you see the amount. We spoke with many professionals, 46 of them, volunteers 20. The people with dementia and care were really less involved in this part, and we really asked for it. But they were less visible. What we saw in our results, there are 3 important topics that are important in building, in developing and sustaining dementia-friendly initiatives. The first one is left on the top, building public support, which is often at an institutional or organizational level. The second topic is an interdisciplinary collaboration, often using interpersonal context. And the last one we saw in all practices, that people were really thinking about how can we motivate people with dementia and their carers to use the initiatives that we are developing. The paper has been submitted, but I have summarized the most important things here. And what you see in all four best practices is that there is a diversity of stakeholders. And that diversity was important for the first mechanisms that are described. There are more reasons, and there should be more reasons to become dementia-friendly, not only because of a vulnerable group of people as they are sometimes presented, but also because there are more interest and more benefits also for other peoples. For example, widening a pavement can also be very nice for mothers who have children. So when you focus on the normality and more benefits for everyone, that opened doors. Another one was sharing resources. If you have a diversity of stakeholders, you are able to share your resources. It could be money, but it could also be something as location or exchanging knowledge. So the importance of a network is there over there. And the mechanisms is a really positive approach, and that people really felt that they were making a difference. And I will come back to that later. And the outcomes that we found was that people were not only doing good things, but they also had a positive feeling of their own input and taking initiatives for dementia-friendly initiative. In the last phase I'm to talk about, we focused on the interdisciplinary collaboration. And we visited 4 sites who had an ambition to become dementia-friendly. You could also see, because of the time, I'm going to, a bit quicker through it. We visited those sites 1 year and a half, and we supported them in developing dementia-friendly initiatives. I have to say it was due Corona, but it was a disadvantage, but it also learned to us what was important. And I included the table to show you how many people were involved. And I would like you to focus also on the people that dropped out. Some of them were replaced, some of them weren't. And in our results, we got to understand more why people dropped out and why they didn't. The results have been based on focus groups, but also on minutes during all meetings, observations and reflections of the researcher and a facilitator. And what we found is that interdisciplinary collaboration is a bit focused on a formal architecture, but the informal architecture are the mechanism which is very important. Of course, you have a municipality needed that with an ambition to become dementia-friendly. They offer facilitation. The diversity of a network, I already explained it, but also a clarity about roles, about manpower. For example, professionals who are involved have to know if they are, developing dementia-friendly initiatives is a part of their work or not. And we saw in the mechanisms that there is a leadership needed which offers structure and support. Group dynamics and equivalence was an important one. No one is more important than the other, and every support and every initiative is acknowledged and for people feeling significant and have a feeling, I want to belong to that group. The last one and most important one learned us why people can sometimes drop out. The activating part, doing something together, was really important. It felt like people had a responsibility and gave them a feeling of significance. And the outcomes, you can also read it, is that developing and sustaining dementia-friendly initiatives is important, is needed, but could also be very fun and offering a group that you really want to belong to. And in the final part, I hope in the future to get more insight on why people with dementia and carers were not part of them, because you should think that they need that also. Thank you very much for your attention.
thank you so much for that really interesting talk. I think the way you've managed to capture the sort of the breadth of the different elements that can make up a dementia-friendly community in terms of the different types of projects which can come within it, but the overlapping areas which are common to all of them, I think are really, really interesting. We don't have any questions online. We may be able to have time for a quick question in the room if there is one. If there's any hands. No, there's not. So what I'll do is I'll move on to our next speaker. If you have any questions about, of course, we have the welcoming sort of reception at the end of this at 6:30. So there's plenty of opportunity over canopy to ask questions of our speakers if you don't think of one during the session. So to move on to our next speaker, I'd like to invite Hevink from Maastricht University to speak on the projective techniques as an innovative dementia-friendly research approach. So Maud, the floor is yours.
Thank you. Thank you, Alzheimer, for offering me the opportunity to present my work here. I'm Hevink, and I'm affiliated with Maastricht University. So today I want to talk about doing dementia-friendly research, demonstrate what we did, and hopefully inspire you to also think about doing dementia-friendly research if you conduct research with dementia. So first of all, I want to look back in time and see dementia-friendly research and how we've come here. So in the past, dementia research was largely seen from a more biomedical viewpoint. And with this biomedical viewpoint, the experiences of people with dementia were not included in research. But with a shift to a more psychosocial approach to research, we started thinking, well, experiences of people with dementia, they are important, they matter. But what we did is we used proxy reports. So we asked carers, informal carers, formal carers about what they thought people would be experiencing. And I think one of the reasons why we did that is because we thought people with dementia cannot participate, they don't have the capacity to participate, they don't want to participate, or we want to protect them. But the last couple of years, we've actually seen more active participation of people with dementia in research. And I think that was really nicely demonstrated this morning with saying nothing about us without us. And I think that also really applies to doing dementia research. So you might wonder what constitutes dementia-friendly research. So I think in its core, dementia-friendly research tries to offer a meaningful experience to people with dementia who participate and treat them as equal. So not only what can I get of our participants, what can we offer them if they participate in our research? And if you think in more practical terms, then there's preparation. So this means training researchers into conducting dementia-friendly research, or really thinking about an adequate consent procedure before you start conducting your research. But it also entails looking at dementia-friendly research methods to use. And what we did is we looked at something called projective techniques. And with this technique, you ask someone to project thoughts or feelings onto a scenario, a picture, a situation, people happening. And then people can reflect on this, and that might allow thoughts or feelings to emerge that otherwise wouldn't have emerged. And I think one of the benefits is that it minimizes the reliance on direct recall. So even those with memory issues can still reflect on that. It might not be their own experience, but it provides still meaningful and useful input. And we hope that doing this also makes it less stressful for people to participate in our research. So what we did in our study is we adapted the use of projective techniques to people with dementia, and we wanted to investigate how it was perceived by them and what it did bring us. So we included 30 people with dementia across 4 countries, being Australia, Poland, the Netherlands, and Canada. And we conducted face-to-face and online interviews during the pandemic. And our topic of our research was diagnosis and post-diagnostic support. So what I want to do is I want to actually walk through our methods with you so you can visualize how it was. So imagine you being the participants for now. So I'll start with the story of Velma and her husband, John. So in this picture, you see a woman. This is Velma. Next to her is her husband, John, and they're sitting at the doctor's. Velma has been becoming increasingly forgetful. She's trouble managing her finances, and she sometimes can't express her thoughts because she's for a lack of words. So in this picture, you see the doctor who've just put her through a range of tests and is just giving her some news. Velma, you have dementia. So what I want you to do is imagine you being in Velma's shoes. What is she thinking? What is she feeling? What is she going through? Anything that pops to mind. So what we did is we gave people some time to write down notes, and after a while we asked them to discuss what they'd written down, what their viewpoints were, and they could comment on what Velma was experiencing or what they were experiencing. Anything that came to mind was valuable. And we used the questions that you see on the side as additional guidance if people haven't already addressed these topics during the discussion. So let's move on. We're a couple weeks later, and here you see Velma sitting on the couch. It's been a couple weeks since she's been at the doctor. She's had some time to think and consider, and we're wondering, again, what is she feeling? What has she done in the meanwhile? Is there something that she hasn't done? And then once again, we give participants a couple of minutes to make notes, and then we discuss. And we use the additional questions you see on the screen to help guide the discussion further. So, moving on, we're a couple of months later, and you see here Velma once again with her husband John. And has anything changed since we last saw her? What has she been doing the past couple of months? What is she thinking? What is she feeling? Are there things that remain the same? And then once again, we give people a couple of minutes to write down any thoughts or feelings, and we start to discuss and use these questions as a guidance. And then we are a year later, coming to the close of our story. So it's been more than a year since Velma and John have been at the doctor's and received the news that Velma had dementia. Despite it being a very challenging year, they also imagine things feeling a little bit more settled. They're thinking about how to move forward with their dementia. And then we ask participants, was there anything that you want to say to Velma or to John or anything else that you want to share? So this was a brief recap of our methods that we used for people with dementia. And what we saw is that people with dementia were able to follow along with the story. They were able to comprehend what we were asking of them. And most interestingly, people had a right variety of responses. So some people talked about what they saw happening in the picture and what they thought Velma might be going through. Others used it to talk about their own experiences. But we also had some participants who were saying, well, Velma might be experiencing this, but what I had was this and this. So we had a wide range of responses there. And what is key in all of these responses was the emotional connection that people had to the story. So the more the story resonated with them, the more meaningful input they were able to provide. So all in all, we got meaningful input out of people with dementia. And I think that's the key that we took away from our approach. And I want to quickly share some of her quotes to demonstrate what I've just been talking about. So in the first picture, you have a person with dementia from Australia that says, well, she's going through extremely shock, probably. But what I have been experiencing is this and this. So she compares and contrasts what she's seeing in the picture or what she's thinking is happening for Velma with her own experiences. And you see this on the bottom half of the screen, you see a person with dementia from Poland. And I was like, if I were in this lady's shoes, I would have lots of questions, which also provides meaningful input in the sense that there probably needs to be more information for people being diagnosed after a couple of weeks. And we can also see that this person from Canada in the top half says, well, a few months later, yeah, well, there might be a lot of changes, there might be no changes, And then she goes in to talk about how carer support is important. And some people also didn't resonate with the pictures. So it might not be realistic to think that after a year, people are happy sitting on the couch. Someone from the Netherlands said, well, I can't imagine being like that. I can't be laughing like that after a year. It's too soon. So people had a wide range of responses that really helped us to think about diagnosis and providing post-diagnostic support. But what can we further improve? As this is just a pilot study, I think there are also a number of issues that arose that we can tackle in future research. So one thing that I would really like to do is talk to those people who participated and see how they actually experienced being part of our research, to really determine from their point of view if it's dementia-friendly or if there's anything we can do to further improve it. And I think that one of the issues is that our pictures are quite stereotypical. They show a white couple with a female being diagnosed, and it might not be representative of those from ethnic minorities or families where there's no husband, or where the children are providing support, or well, there's a wide range of situations where you can think about it. And I think we also need the materials to reflect those situations that someone is in to further increase that emotional connection that's been really, really important. And one way to achieve that is to co-design those materials, which once again goes nothing without us, about us. And that was all I had to tell you today. So I hope I offered you some inspiration, and yeah, feel free to ask any questions.
Thank you so much for your presentation. That was really interesting. I hadn't ever heard of the projective technique before, so to learn more about that and how it was applied here for me was really interesting. I have a couple of online questions which I'm going to put to you. I'm going to ask this slightly less controversial one first. So the first question is, how do you navigate using stories in dementia research? Do you find that people find it difficult to understand it's fictional?
Well, for some people, we try to explain that it's a fictional story for the people. But for some people, it can be quite emotional. And I think in Canada, there's one person that got really, really upset. And then she started crying during the research, which also, I think, indicates that you need to be really careful with what stories you pick and how you tell them. Yeah, and we hope that people can better reflect on their experiences. Yeah.
That's great, thank you. And the second one, I guess it's controversial, maybe it's more difficult. It says, do we think that dementia-friendly is the right term anymore? It's been used by businesses, and perhaps dementia-enabling is less passive.
Well, excuse me, could you repeat? You speak very, very fast, please.
Apologies. So the question from there was, do we think that dementia-friendly is the right term anymore? That's been used by businesses, and perhaps dementia-enabling is less passive.
I think we can opt for a wide range of terms. I'm not against dementia-enabling techniques. The research, I think it's just a matter of making research more appropriate to including people with dementia. I think the term is not really central there.
And are there any questions in the room? The gentleman at the front with the microphone, please.
Yeah, just on that, just on that point of dementia-friendly, I think it is important because we don't have cancer-friendly communities or diabetic-friendly communities. But if you have dementia, you're expected to be in a dementia-friendly community. I live in a dementia-friendly community. My doctor still speaks to my wife rather than me. So it's nonsense. It's time to examine, or maybe the question is it time to totally re-examine the language?
Thanks for that. I think it's a good point. I think it's one that I've seen when we did the yearbook last year, and the literature, I think you've seen it, it's trying to find something and hit on something which really encapsulates and really does communicate what the effort is and what the intention is. hasn't yet been found, and I think it's something we need to, you're right, I think we do need to look at it, and it'll be an ongoing discussion, I think. Just in the interest of time, I'm going to move on to the next speaker, if that's okay. Thank you very much for your presentation. So our next speaker is Nikki Lorimer from Alzheimer Scotland. I know we have two Scottish people here, it's not a conspiracy, I promise you. And Nikki is going to present today on building positive educational partnerships. Nikki, please.
Thanks. Hello, as Owen said, I'm Nikki Lorimer. I work with Alzheimer in the National Post-Diagnostic Support Team with Alzheimer Scotland. And I was first given the opportunity to offer student placements in October 2019 and have since been leading and developing on this type of partnership working within Alzheimer Scotland since October 2021. Today I'm going to share through my presentation the way in which Alzheimer Scotland works in partnership with educational establishments and the way those partnerships benefit the student, Alzheimer Scotland, and ultimately, and most importantly, how those partnerships will benefit people living with dementia, their families and carers. Initially, we worked in partnership, our first partnership was with the University of St Andrews, who have a programme called ScotGem. And ScotGem is a 4-year graduate entry medicine programme. So everybody who joins that programme has already done a degree and they're joining that to study medicine for a further 4 years, which I think in itself is quite exceptional. So the programme is run by the universities of both St Andrews and Dundee, and it focuses on encouraging graduates to become generalist practitioners with experience in rural healthcare. The focus is to produce high-quality, multi-skilled and compassionate clinical leaders who have the enthusiasm, competence and confidence to influence change. Students contribute to local communities and the health service whilst training through supported Agents of Change programmes and projects. The students learn and attempt to bring about real change in healthcare settings through understanding, developing and practising the skills required to generate change. An agent of change will identify opportunities for improvement by leading, engaging and working with staff, patients and communities whilst they are students and when they are qualified doctors. They will empower their patients and staff to drive forward positive change and will have a future focus and wider systems thinking approach to health and social care. And Alzheimer Scotland support the Agents of Change with placements under the Service Learning Community Engagement theme. So what do we mean by service learning and what are the outcomes? This is what service learning is. Service learning is a credit-bearing educational experience where students participate in an organised service activity that meets identified community needs. And then they reflect on the service activity in such a way that they can gain further understanding of course content, a broader appreciation of the discipline, and an enhanced sense of civic responsibility. So why service learning, and what does that bring to the student? What does it bring to Alzheimer Scotland, and why is it a dementia-friendly initiative? So these are the expected outcomes from service learning, but how do we achieve those? A placement with Alzheimer Scotland allows students to meet people and see them in their own environment rather than in a clinical setting. The students will see people as opposed to a symptom or a diagnosis, in this case a diagnosis of dementia. They will begin to understand the barriers that people face when living with dementia and perhaps understand the circumstances of people's lives. They become aware of the richness and diversity of community responses and their contribution to public health. They form connections and gain lived experience. It also gives them the opportunity to see the way the systems work, to identify gaps and perhaps develop improvements. So how do we deliver this placement? Initially, the students meet with colleagues from across the organisation and see how the staff collaborate to support the health and well-being of people living with dementia, their families and carers, whilst gaining an understanding of the challenges third sector organisations face. Through discussion with the students, we identify an area or areas of particular interest to them and give them the opportunity to work within that area. For example, it might be post-diagnostic support, carer support, a registered day service, or some community activities. This gives an opportunity to meet people living with dementia, their families and carers, and hear firsthand what that diagnosis has meant to them and how Alzheimer Scotland's approach has supported them to live well and meet their planned outcomes. The students attend frontline supports in person, meeting people living with dementia, their families and carers, and this positively impacts the students because the experiences of those living with dementia becomes more accessible and better understood. They recognise the value of peer support. They develop empathy and engagement skills through supporting people with lived experience of dementia. It encourages them to challenge perceived stigma, and it leads them to promote compassionate care and therapeutic interventions. The Alzheimer Scotland placements meet these learning outcomes and empower students to become general practitioners who consider alternatives to conventional healthcare interventions and to deliver person-centred care, which in turn empowers people living with dementia, their families and carers, in addition to increasing efficiency in healthcare settings. Students feedback that their experience is informative, meaningful and unique, giving them an insight into the role of third sector organisations within health and social care. So what's next? Following our initial successful partnership with the University of St Andrews, we are now working with them and other universities, including the University of Dundee, on a continual rollout of service learning placements. We have 2 ScotGEM students starting on the 25th of October in person, and students from the University of Dundee Medical School joining us in early 2023. Through this collaborative project, Alzheimer Scotland provides new and innovative and crucially interacting learning experiences, which influence how students will practice and develop as general practitioners, with a real insight and understanding of non-clinical interventions and supports, which provide people living with dementia, their families and carers with the tools, connections, resources and plans to allow them to live as well as possible with dementia and to prepare for the future. Thank you.
Thank you so much for that really interesting presentation and for the really interesting work that's been developed by Alzheimer Scotland. I know this is an area where I think there's been a lot of talk about questions around how do we make sure that clinicians are informed about dementia and how do they reduce stigma in terms of the practice, and I think that was a really good example of one example of a programme that could be used to do that. Do we have any questions from the floor about the programme? If not, then I'll say thank you for your presentation and I will move on to the next speaker. So, our next speaker is Birgit Dietz from OTH Amberg Weiden and the Bavarian Institute for the Elderly and Cognitively Impaired. And she's going to present to us today on a project to analyse accessibility for patients, even those with dementia, at Bavarian Hospitals. So, please, the floor is yours.
Thank you. Great to be here and having the chance to speaking to you about an analysis we made for the ministry in Germany. It's pretty loud in here. They asked us how barrier-free are the Bavarian hospitals. Well, the first thought we had was in Germany, the DIN standards doesn't include anything we wanted to look at. It's about wheelchair users, it's about people with seeing impairments, but it's not about cognitive impairment, and it's even not about hearing. So we thought we should ask what they are thinking about with this question, and which persons or which patients they want us to focus on. And we've been pretty glad that they haven't had the opportunity that we only had to talk about stairs and elevators and ramps or things like that. But we had the chance to think about the things which are written down in the UN Convention on the Rights of Persons with Disabilities. And that does mean it really is a holistic approach, and we could look at very different things in this study. Because in this Article 1, there you can read, the purpose of the present convention is to promote, protect, and ensure the full and equal enjoyment of all human rights and fundamental freedoms by all persons with disabilities, and to promote respect for their inherent dignity. And persons with disabilities include those who have long-term physical, mental, intellectual or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. So the problem we saw was that we've got a lot of questions, and to put that in one study was really pretty difficult. So we had a team from the Architects' Chamber in Bavaria, from the TÜV. I don't know whether you know that, I don't know the expression in English, I'm sorry. And a few others. It was a team with 5 who, were thinking about the themes. And we had the chance to start with a phase of exploration where we did a lot of interviews. And we did interviews with staff and, of course, with people with dementia as well. And there were a few questions we could add to the questionnaires coming out of these interviews. For example, one, I've never thought about that, whether it's possible to to take a dog into the hospital with a person with a seeing problem, but of course with the people with dementia or cognitive impairment, because we know that it could calm down very, very good, and it's a kind of, feeling at home. The ministry at first said, we think there are big hygiene things and I don't know what, but it wasn't. So we've got a lot of themes. We've had, I think, 480 questions after our phase 1 exploration with a systematic literature review and a review of existing checklists on top. Then we had the phase 2, the analysis, and then the phase 3, of course, the documentation. It lasts 1.5 years, so it was a really long-term research for us. Then there was the idea of taking 3 dimensions of accessibility into account. We had the objective dimension, which is, testable. It's the standards and all these things. Then we had the subjective perspective, and saw that everybody has another awareness of his own situation, and not everybody with the same problem has got the same feeling as the others. So it's really very personal how you behave in the hospital, or how you feel yourself in this very critical situation, perhaps. So the third one was the process accessibility, meaning work environments or qualifications, workflows and all that. And we saw that there was a big influence with the pandemic things because current processes, changes, and nobody was used to them. So it was a bit critical, even the time we did the questionnaire. The next one was to get a 3D model where we tried to put all these things together to find out which questions are the best one or the ones we want to ask now. So we took these 3 dimensions, objective, subjective, and process. Then we put it together with the different people being in the hospital, meaning not only the patients, but even the staff and, of course, the relatives, for example, and then trying to find out, well, where the problems start. And they really started already with the wayfinding from the parking place to the info point, and that not only for people with cognitive impairment or well, limited knowledge of German, but as well for people in wheelchairs or for people with mobility aids. This was very amusing for us because the ministries thought that, of course, they had a lot done already for people with wheelchairs, for example. The next theme was orientation and wayfinding, and we looked at signage and orientation systems. And you can see that there were a lot of things just where the symbols understandable or readable, and signage with contrast, so very, very easy things to manage. But even less than half of the hospitals said, well, we have easy readable symbols, but much more than half of that said, well, there we don't have signage with good contrasts. So we talked about safety, and we saw that there are pretty easy points not thought about as well. So, for example, sufficient staff to support, and that's what, of course, for example, people with dementia would need. Or another thing was evacuation from top floor without any steps possible. So only in 16% of the hospitals was that okay. After that, we thought we have to go to a lot of hospitals ourselves and made a test whether that really is what happens in the hospital. The next one was about nutrition for people with impairments, and of course, I will look at a special food for people with dementia as well, talking about finger food in this research. And you can easily see that there weren't a lot of hospitals offering things like that. And even when you're speaking about communication and service and thinking about special things for this group of persons as well. Oh, I'm too. Oh, doesn't. Yeah, no, thank you. A bit more than half of it has rooming in. Not the half of the hospital said we have an engagement for activities to help with daily structure, a delirium management, or extended wayfinding strategies. So there is a lot to do in our hospitals, especially for people with dementia, but there are a lot of barriers. The conclusion would be the self-assessment of the participants of the questionnaire was pretty optimistic. The hospital said, and these were nearly 100% accessibility is an important topic in our hospital. But in the Bavarian hospitals, they offer various solutions in terms of their accessibilities. However, a need for action to improve accessibility was identified in many, many parts. For people with dementia, there would be a lot to do. And we think that, however, older people with impairments and people with dementia have not yet been taken into account, despite comparable needs. And barrier-free stay for people with dementia in the hospital is currently made considerably more difficult. We asked what are the barriers, and at first we thought perhaps it's financial resources, but you can look at that, it's not. The most say we strongly agree that it's the internal processes, and then there are much too many other tasks and things like that. So we have to think about raising awareness, of course. We have to think about holistic approach. We have to think about barrier-free work environment in the hospital, and we ask the ministry to make a more specific evaluation, taking a few hospitals and visiting them. Then we have to optimize coordination of processes. We have to think about funding practice, and we have to think about update, for example, the space program. So that was it. If you have any questions, I think there would be a minute. Yeah, thank you so much.
So we do indeed have a couple minutes for questions. Is there anyone in the room who has a question to begin? Just the lady there. Just, can you wait for the microphone, please?
Yeah, you mentioned TÜV is an organization. TÜV is an organization for accreditation. That's a TÜV.
Okay, thank you so much.
This is what I love about your conference.
I think I would have it in my notes, but I can't see my notes there.
I have a question from online. So the question is, how do you bypass barriers when working within older buildings which may be registered to protect the architecture?
Yeah, this is a pretty broad thing. I think it's much too difficult to answer that now. Of course, there are differences, but we can say that an older building is not that sufficient or more or less sufficient for barrier-free or not barrier-free than others. Because in the older ones, you have a lot of space. Often you have got a lot of space, for example, in the corridors. This is wonderful to find a place to sit down, to have a rest, to go a few steps or I don't know what. In the new hospitals, there often is such a lot of thinking about making things very quick, having very short ways, not making rooms big enough and all that. That I can't say that the elder ones are, well, more bad or less bad than the newer ones. But I think this is a really big topic, and perhaps we can talk about that in the evening, or the person could write an email.
Indeed, use our virtual conference platform to send you a message, because you can send a message to anyone on the platform, so please feel free to do that. I'm going to ask a question of Nikki, just because one came up literally just as Nikki sat down before. So to ask you, how do you navigate sharing learning of the effects of stigma alongside a focus on prevention and cure, which can also add to stigma?
So, first thing is, how do we navigate?
Yeah. How do you navigate the sharing learning of the effects of stigma, so with the students, whilst alongside focus on prevention and cure? So how do you balance both aspects of stigma?
I think that's absolutely by sharing experiences with those living with dementia and their carers. They will share their experience of stigma, but also the support that's available, and I think that's how we do that. It's all about that first-hand and lived experience, rather than, it's not about me telling them, it's absolutely about the discussions, the we have in person with those people that we support.
Thank you. Thanks so much. So we come on to our final speaker of the day, who is Chani Yavin, who's from the Danish Alzheimer Association, and she's going to talk about how volunteers help people with dementia maintain a social network through a common third. So please.
Yeah, thank you so much. All right. So yeah, as presented, my name is Chani Yavin, and I work as a project manager for the project Activity Friends, which I'll present to you today. And I do that at the Danish Alzheimer Association, which is actually the only patients association in Denmark working for people with dementia and their relatives. And we do work for quite a large group in Denmark with around 90,000 people who is diagnosed with dementia and 400,000 people who are directly affected by the disease. All right. So I'm going to present Activity Friends. I'd like to start with telling you why we even created the project to begin with. As all of us know, dementia is yet incurable, but research shows that maintaining a social network and activities can help prevent and even delay cognitive impairment. We also know that even though you have a dementia diagnosis, your need for social activities and an active life doesn't disappear, but dementia can make it hard to do the things that you love. So that's why we created Activity Friends, to help people with dementia continue being a part of social activities and maintaining an active life. Activity Friends is quite simple as a concept. We match volunteering Activity Friends with people who have dementia so they can meet over a shared interest. In this way, the volunteers making it possible for a person with dementia to maintain an active life. Meanwhile, the volunteer is also doing something they themselves find fun and interesting. So in other words, we let both parties build a relationship that is based upon a common third. In Activity Friends, we also build relationships in which both parties actively express that they actually wish to be matched with each other. We experience that this has a positive impact on feeling a sense of equality, and it also creates a focus on the persons involved rather than the disease. The project includes all types of dementia, as well as it includes people who are still living at home or in a nursing home. Today, we're about 1.5 years into the project, and I would like to share with you the elements of the project, some learnings, and of course, the results as of today. All right, first a little bit how we did it. Activity Friends consists of 4 core elements for the project to even exist. So first we started by building collaborations with municipalities. More specifically, we collaborate with the dementia professionals who are working in these municipalities and who has a daily dialogue with the people living with dementia. In this way, the dementia professionals play a big part in the initial screening process to make sure that Activity Friends is offered broadly in the right life situations and at the right time of the course of the disease. Second, we recruited a corps of volunteering match leaders who is situated locally in these municipalities with whom we are collaborating. And the match leaders are actually quite key to this setup, since they are the ones actually creating the matches and making sure that both parties have what they need to succeed in the new relationship. Third, we created an IT system that is specifically designed for volunteers to be working in it. So for example, the match leaders can make calls, send texts, and even emails through the IT system, making sure that they can keep their own private phones and emails out of their roles as being volunteers. So in other words, this IT system is designed to function as a workspace for them, and it is also their main tool today. And finally, we were ready to recruit and onboard volunteering Activity Friends to create matches with people who have dementia. 3 of these elements are scaled each project year, so each year add more municipalities to the project. We recruit more match leaders to create matches locally in these given municipalities. And of course, we recruit more Activity Friends to create new matches. Activity Friends began in April 2021, and it goes on until September 2024, which makes it a total of 3.5 years. And the goals that we aim to reach at the end of the project are as follows. We aim to build and develop collaborations with 20 to 25 municipalities. We are recruiting and onboarding 30 volunteering match leaders, And lastly, we aim to recruit and match 300 people with dementia as well as 300 activity friends. All right. So next, I would like to present to you with the learnings and the insights that we made through this year and a half that we've been working on Activity Friends. It is more specifically the learnings of the people involved, being the volunteers and the people with dementia who are looking for an activity friend. The first 6 months of the project we spent on developing the IT system as well as the processes needed for recruiting and onboarding people with dementia as well as the volunteers. So this means that we have actively been matching for about a year. All right, so if we first take a look at who the volunteers in this project are, and this means both the match leaders and the activity friends. We typically see that our volunteers come into this project with a background either as relatives or to a person with dementia. It could be maybe a parent or a grandparent, or we experience that they come from a professional background, meaning that they are working in the field of dementia. We see that the age average is typically is now 34. This is especially due to that we have great success in recruiting the younger volunteers. So they sign up typically in the beginning of the 20s. And finally, we see that we have an overrepresentation of female volunteers with a whopping 81% of them being women. And working with volunteers in general, this is not a great surprise, since it's generally women who tend to sign up for roles like these. But the fact that our volunteers do have a close and personal understanding of an experience with dementia and people who live with the disease makes it possible for them to enter their role as activity friends or match leaders in an understanding and very present way. So, in other words, they are, due to their background and experience, equipped to meet the person first and the disease second. Okay, so next we're going to look at the people with dementia who are looking for an activity friends. Activity friends is aimed at people with a mild to a moderate state of dementia. If the course of the disease is too progressed, then there's no longer a need for a volunteer, but more need for professional care and insight. The age average is 80 years, but of course we also know that age does not necessarily influence the progression of the disease. Today the youngest person we matched is 49 and the oldest is 101 years old. Which I think also shows the broad range and potential of inclusion a project like this has. And finally, we see that it is again primarily women who signs up and are looking for an activity friends, with 66%. Okay, so I've talked a little bit about the backgrounds, the elements that it consists of, and the elements that's necessary for the project to exist. And of course the learnings. Next, I would like to show you the current results as they are today. Today we have collaborations with 10 Danish municipalities. This number will reach 15 at least in April next year. We have recruited and onboarded 12 volunteering match leaders who are situated around these 10 municipalities and who are making the matches. We have recruited and onboarded 121 people with dementia, as well as 117 volunteering activity friends. And in this year that we've been matching, I'm very proud to say that we also created 94 matches, and there are only more to come. But the most important results, I think, are the relationships that we actually succeed in creating. And that's why I want to finish off with a video that I brought with me today, showcasing a relationship between Clara and Henne. Clara is an activity friend. She lost her father to Alzheimer's last year, and she is matched with Henne, who has dementia. Oh, there is something with the sound.
Det glemte du. Det var det med den der dementia. Nå. Det er noget af det bedste, jeg har ønsket længe og fået en. Men jeg var også i tvivl, var det en, der kunne med. Men så kom sød og klar. Og det matcher bare lige. Vil lige skrubskøre begge to?
Ja, lige præcis. Det gør meget for relationen af vores interesser. Minder om hinanden, og man bliver matchet ud fra det. Der er noget fællesskab, vi kan finde i hinanden. Hos os er det jo meget det her med at gå ture, være lidt, nogen siger mærkeligt, vi siger fantasifulde. Ej, og så forskelligt. Det er en afkobling fra min hverdag, når jeg kan være sammen med Hanne. Fordi man ligesom kan stille sig lidt væk og få de her par timer om ugen og hygge sig med det.
Det er Rosenborg. Hvor er det flot. Der er der en, der kan følge en, som gør en tryg. Og det gør jeg klart. Jeg har det afslappende, og føler, at jeg kan bare være mig.
Vi finder hinanden, hvor vi passer, selvom alderen er forskellig.
Det er også nogle gange rigtig godt at høre en mening for en ung en.
Og i lige måde den anden vej. Det giver meget at høre en, der har lidt mere livserfaring end andre veninder. Så det er en god ven, man får.
Ja, forhåbentlig en ven for livet.
Ja, det er planen.
Ja, det er planen. Og den der er ikke nogen, der kører lidt. Nej.
Yes, and of course, thank you to the foundation making this project possible, and thank you for your time. All right.
Thank you so much for a really interesting presentation. It was a really, really nice scheme, and it's a really lovely example of how to create sort of those connections between people with volunteers and people with dementia. I think that's a really, really nice way to round off our session. There is one question online, which is, how do you actively encourage different groups to volunteer that are less represented?
Okay, so I'm not quite sure what they mean with less represented.
I think they meant, so for example, the fact that it was like 80% women. How do you get more men involved? How do you get different age groups involved, perhaps?
Yeah, so that's a topic we talk about every day, how to get the men to volunteer. But not just the men, also people who are not directly affected by dementia in their everyday life. And I think the key in a project like this is to talk about the activities. So you, as a volunteer, you are good at something and you have an interest in something, and that interest can be shared with another person. The dementia is not the primary thing here. It is the shared interest that you can have with each other and the strength that is in that relationship. So I think that is a way you can talk it up a bit. And of course, to demystify dementia totally. I think if you don't have dementia in your life, or you don't know anything about the disease, like I think with many other diseases, you can get nervous and maybe think that you can do something wrong, so you tend not to volunteer for stuff like this. So I think that we also have a responsibility to show videos like these and to show that it's not that scary to be a volunteer in a project like ours. Yeah.
Thanks so much. Do we have any questions from anyone in the room? A gentleman at the front.
Thank you. I mean, you've kind of touched on bits of what I'm curious about Chani, but I'm from Scotland, and in Scotland, volunteering is traditionally generally done by older people who are perhaps retired and have more time. How were you so successful in getting such large numbers of younger people to get involved?
All right, so the answer is actually quite boring. A lot of the young people are studying how do you say, like studying for a health profession. So that is, and they're not volunteering because they want extra credits or something. It's because they have a natural interest in other people. So it's very easy for them to volunteer for this. And actually some of the longest matches we have are with the young students going up for, I think, the year that we've been matching so far. So I think it's quite a special group to include in a project like this.
And just we're coming to the end of the session. Do we have one last question, perhaps? Just there.
Why is it that people with half a leg can park nearby hospitals and people with mental disease can't, because my orientation is 0 and it's a problem for me. So why can I not park in the front, you know, because I have to find my car again?
This is a very good question. I have to write that down for the next round of questionnaires, because well, my mother-in-law is afflicted with dementia, or was afflicted with dementia, and we had a lot of really incredible situations in hospital. So I can understand what you're talking about, and I really have no answer to this pretty good question. Thank you.
I'll take the gentleman at the back, and that will be our final question to wrap up our session.
Hello, just a response to your question about using priority parking. In the UK, once you have a diagnosis of dementia, you can qualify for a blue badge, which entitles you to have priority parking, and that's assigned to the person, not to the vehicle that they're in. So it can be done. You just have to work with the municipalities.
So we have to move to...
No.
That's an elegant solution to a complicated problem, but I think there is a variation across countries where some places the blue badge is eligible if you have dementia, and some places it isn't. Okay, I'm going to tell you about absolutely the last question because we are now way up to run over time.
We don't have to move. We have to put it towards the EU to make it a rule for all the European countries. And when the EU is on this side, then we can maybe also get all the countries that are not members of the EU to follow. So we have to take it up to the EU level. Does anyone from Alzheimer Europe around here? They can take it up in the EU, right?
The policy officer of Alzheimer Europe is chairing the session. So it's
Thank
definitely
you.
something that we will look at, and definitely something we'll look to raise, because there will be a number of MEPs, I'm sure be very supportive. Yep.
We have the European norm about barrier-free things now, and it's much better. It's only a half year ago or something in Germany, so perhaps in other countries a bit earlier, but it exists since 1.5 years, I think. But a lot of countries doesn't do just ignore these barrier-free EU norm, because their cognitive impairment is a theme. And this would be a pretty good thing for the Alzheimer's Society to care about that, and to look whether in every country the things which are in that norm or in this standard are implemented. So this was a pretty good thing. Thank you for this last thing. Yes.
It's definitely something that I think we should look into further, and we should definitely look into, because there's things like the EU Accessibility Act. The EU's done work in this area, in recent years, but it's something that we can definitely raise and definitely make more of a noise on that subject. So just to finally say thank you to our incredible panel of speakers today. We've had the full range of, when I said that dementia-friendly communities or dementia inclusiveness covers a range of topics, I think we've really seen that today, from conceptualizing it to research, to education, to hospitals, and then finally to volunteering. I think we've really got a sense of the full range of work which is going on, or at least some of the work that's going on. And just to say a final thank you to our speakers, and to say, of course, please join us at 6:30 for the reception this evening. So thank you all for coming.